ALS Physiotherapy Management Part 2. Chair glides or stairway lifts can be suggested for those individuals who live in multi level homes but who cannot or should not climb stairs. These lifts are measured and custom made for individual staircases and are very expensive. Insurance companies usually do not reimburse for stairway lifts, but some medical supply companies offer rent to own options. In addition, local ALSA or MDA chapters may have lifts that have been recycled. At some time point as the disease progresses, the extent of muscle weakness or the energy requirements for the ambulation will necessitate wheelchair use for mobility. In the early or early middle stage of ALS, a manual wheelchair, preferably lightweight, may be used for traveling long distances as an energy conservation technique. This wheelchair should be rented on a short term basis or loaned from a local ALSA or MDA chapter or other source, because most insurance companies will reimburse for only one wheelchair purchase. As the disease progresses, a power wheelchair system tailored to the patient's current needs and potential future needs will be necessary. Numerous customized wheelchair features and options are available that can assist the individual in maintaining a maximum level of independence and comfort. A referral to a wheelchair and seating clinic may be the best option owing to the numerous specialized and evolving needs of the individual with ALS. Trey et al. Surveyed 42 patients with ALS and moderate disability, as documented on the AALS, about the wheelchair features they found most beneficial. 61% of patients report that their wheelchair allowed them to maintain their previous activity levels. In order of priority, manual wheelchair users cited a lightweight frame, small turning radius, high reclining back, and supports for the head, trunk, and extremities as most desirable. Undesirable features included low sling, reclining back, non motorized, static, non adjustable leg rests, heaviness or large size, and non removable armrests. Desirable features for patients who are who used powered wheelchairs included independent mobility, maneuverability, overall comfort and tilt in space or recline features. Undesirable features included low, non reclining back, heaviness or large size, uncomfortable seat, non adjustable leg rests, and general discomfort. Although power scooters may be suitable for a patient with adequate upper extremity and trunk strength in the early stages of ALS, the vehicle becomes limiting as the disease progresses and should not be prescribed. If the patient has already been reimbursed for a scooter, most insurance companies will not pay for a power wheelchair because a scooter is considered a power mobility device. If a scooter is to be recommended at all, the patient should rent or borrow the device for short term use. Muscle cramps and spasticity. Muscle cramps may be alleviated with massage and a stretching program. Cold can temporarily decrease spasticity. Physical therapists can perform and instruct caregivers in slow, prolonged stretches and passive ROM exercise to address spasticity. In addition, postural and positioning techniques can be incorporated to decrease spasticity, and splinting may be necessary to prevent contractures. A published Cochrane review identified one randomized controlled study that found patients with ALS who engaged in a 15-minute twice daily moderate intensity exercise had decreased spasticity as measured by modified Ashworth scale compared to a control group who engaged in usual daily activities. Psychosocial issues. A diagnosis of ALS is devastating for both the patient and family caregiver unit. Because of the progressive nature of the disease, impairments readily lead to activity limitations and participation restrictions, which may affect quality of life. The emotional responses of the person experiencing the disease, family members, and individuals caring for the patient are multifaceted and may fluctuate throughout the stages of the disease. Much is lost when living with a terminal progressive disease. physical health and abilities, body image, work and family roles, identity, family and social networks, lifestyle, independence, control, hope, meaning, and the anticipated future. The physical therapist must be able to recognize the patient's ability to cope and adapt, and his or her psychological reactions, level of acceptance, and willingness and ability to integrate therapeutic recommendations. It is also imperative that the physical therapist be able to differentiate between normal reactionary grief to losses or a change in physical function and the presence of clinical anxiety and depression, and refer the patient to the appropriate healthcare team member when necessary. When pervasive anxiety and depressive symptoms need to be treated aggressively with psychopharmacological medications, because left untreated, these psychosocial impairments can adversely affect an individual's ability to adapt, cope, and participate in the POC. Depression may also lead to suicide. In addition, anxiety and depression may also be prevalent among family members or caregivers. Exercise and ADL, ALS. Despite the high incidence of muscle weakness in individuals with ALS, the effects of exercise programs have not been extensively studied and thus are not well understood. Often, physical therapy programs involve ROM and stretching exercises only. Despite the lack of research evidence, some discourage exercise programs because of fear of overuse weakness and believe that no exercise other than everyday activities is indicated. Studies of individuals with other neuromuscular disease such as polymyelitis, Duchenne's muscular dystrophy, myotonic dystrophy, hereditary motor and sensory neuropathy, spinal muscular atrophy, and limb girdle, Becker, and facioscapulohumeral dystrophy have found that exercise programs are beneficial and do not produce overuse weakness. The research evidence from these patients' populations suggests the following. Overuse weakness does not occur in muscles with an MMT grade of 3 or greater out of 5. Moderate resistance and exercises can increase strength in muscles with an MMT grade of 3 or greater out of 5. Strength gains are proportional to initial muscle strength. Heavy eccentric exercises should be avoided. Exercise may produce functional benefits. Psychological benefits have yet to be determined. When prescribed appropriately, exercise may be beneficial, especially in early stages of the disease. Exercise may not improve the strength of muscles already weakened by ALS, certainly not those below grade 3. However, in general, active ROM and stretching of affected joints, resistive strengthening exercises of unaffected muscles with low to moderate weights, and aerobic activities such as swimming, walking, and bicycling at submaximal levels may be prescribed. When designing a strengthening exercise program for a patient with ALS, the physical therapist must take into consideration the balance between overuse fatigue and disuse atrophy. Evidence from patients with other neuromuscular diseases suggests that highly repetitive or heavy resistance exercise can cause prolonged loss of muscle strength in weakened denervated muscle. Some animal studies have found that neuromuscular activity has inhibitory effects on sprouting in partially denervated muscle, whereas other studies have reported no effect or that activity can promote sprouting or reinnervation. On the other hand, a marked reduction in activity level to ALS can lead to cardiovascular deconditioning and disuse weakness beyond the amount caused by the disease itself. Therefore, the type and intensity of the exercise program should be carefully monitored and adjusted by the physical therapist in order to prevent excessive fatigue while at the same time promoting optimal use of intact muscle groups. Patients should be advised not to carry out any activities to the point of extreme fatigue and should keep track of symptoms of overuse, such as the inability to perform daily activities following exercise due to exhaustion or pain, increased fasciculations, or increased muscle cramping. They may also be advised to exercise for several brief periods throughout the day with sufficient rest in between. Disuse atrophy. Reduced physical activity, particularly if prolonged, reduces function of the neuromuscular system in addition to the skeletal and other organ systems. With increase with insufficient activity, disuse atrophy develops when muscle contractions are less than 20% of the total tension a muscle is capable of producing. As contractile proteins are lost, the muscle weakness progresses at a rate of 3% per day. Strength loss through inactivity and disuse can significantly debilitate individuals with ALS, making them highly susceptible to deconditioning and muscle and joint tightness, leading to contractures and pain. Overuse fatigue, the potential for including overwork damage in individual with ALS through excessive exercise is a common concern. Sanjay et al. Found that individuals with ALS demonstrate abnormal physiological and metabolical responses to single bouts of exercise. Oxygen consumption during submaximal exercise was increased in individuals with ALS compared to controls, and VO2 max and work capacity were decreased. In addition, it was found that several metabolic substrates of plasma and muscle compartments did not increase to the same level as untrained control subjects, indicating that the availability of substrate for energy production is affected. In individuals with ALS, the safe range for therapeutic exercise narrows, and the degree to which the range narrows is dependent on the extent of disease involvement and the rate of disease progression. A weak or denervated muscle is more susceptible to overwork damage because it is already functioning close to its submaximal limits. Activities of daily living alone may cause impaired muscles to act as though in training and exercise that would improve normal muscles may actually cause overwork damage in impaired muscles. The remaining motor units will respond to training, and those motor units must work harder to handle a given amount of exercise stress. Thus, special attention must be paid to developing an exercise program for patients with ALS, and physical therapists should prescribe exercise training at moderate to low intensities. The literature related to exercise in individuals with ALS limited. Two early case studies demonstrated positive effects of specific strengthening and endurance exercises. More recently, the effects of exercise in individuals with ALS have been evaluated with larger samples. Both of these studies found significantly less decline in function scores and other outcome measures in the exercise group. Two animal studies found that endurance exercise training at moderate intensities slowed disease progression. A third study found that high endurance exercise training had detrimental effects on male mice only. The evidence related to exercise and ALS is presented in box 17.1, evidence summary, animal studies. Patient client related instruction. A diagnosis of ALS is devastating for individuals and their families. They are faced with continual multiple changes and losses and eventual death. Assisting the individual and his or her family and caregivers to come to terms with the impact of the disease is an important role for the physical therapist, and providing psychological support and opportunities for expression of feelings, frustrations, and concerns is imperative. Collaborating with and educating the patient, family, and caregivers in an open and encouraging environment may empower patients in their efforts to cope with their disease, foster a sense of purpose and self efficacy, and enhance the overall effectiveness of the intervention by increasing adherence with recommendations. Patient and family or caregiver education is integral throughout the stages of the disease. The scope of education can include, but is not limited to, the following: providing accurate, factual information about the disease process and clinical manifestations and their significance in terms of management, Give only as much information as the patient, family, and caregivers need. Information should be provided in a manner appropriate to their understanding, instructing patients, family members, and caregivers regarding the interventions that can be carried out independently, such as monitoring the effects and side effects of medications, use of assisted devices and adaptive equipment, and preventing secondary complications. Advising the patient about methods to promote general health, instruction regarding energy conservation, balancing rest and activity, and relaxation techniques may be beneficial in assisting the patient to cope with the daily constraints of the disease. Counseling regarding care and life decisions if the patient asks about these issues. Referring patients to support groups or psychological counseling, providing information on health and available social and support services. The ALSA and the MDA are two national voluntary organizations that provide many functions and program for individuals with ALS and their families and caregivers, including the provision of written and video educational materials and local education programs, patient and caregiver support groups, equipment loan programs, respite programs, transportation programs, advocacy programs, and ALS awareness programs. Patients and families can contact the ALSC and MDA for information and explore available resources on the websites. In addition, there are numerous international organizations whose websites provide a variety of resources, including information about ALS, information about clinical trials, evidence based reviews, evidence based practical guidelines, and publications about living with ALS. Summary: amyotrophic lateral sclerosis, the most common and devastatingly fatal motor neuron disease among adults, causes a progressive increase in the number and severity of impairments, activity limitations, and participation restrictions. Other than a small percentage of cases, etiology for most part is unknown, and it is hypothesized that multiple mechanisms may be responsible for the disease. Although there is no cure for ALS and its course cannot be altered, it should be considered a treatable disease. Medical management is primarily symptomatic, and a team approach to care is considered optimal. Rehabilitation management is focused on maximizing function and promoting independence to the highest level possible and ensuring optimal quality of life throughout the course of the disease and across healthcare settings. The physical therapist plays an integral role in designing and implementing therapeutic interventions for individuals with ALS that will allow them to maintain independence and function for as long as possible. The selection of interventions grounded in evidence based research, whenever possible, is based on the stage and progression of the disease and may be restorative, compensatory, or preventative. These interventions should take into considerations the individual's goals and psychosocial factors that may affect decision making, such as individuals' acceptance of the diagnosis and the individual's social and financial resources. Because of the progressive nature of the ALS, the physical therapist must not only address the patient's current problems but also plan for the patient's future needs. Thank you.